I'm sure people in the audience, especially the ones who work on insurance and such risk models are sort of asking the question, well, we knew that it's hard, this is uncharted territory, there are uncertainties, there is lack of data. So I'm going to let people in the audience ask questions to our panel here, risk modelers who work on trying to quantify pandemic risk. Any questions in the audience? I have a few of my own, but I'll let others ask first. Yes.
So I was struck by the comment of saying, let 1,000 flowers bloom, because I do think it's critically important that we do get more models working. The thing that we need to think about, that it's both, is a pandemic going to happen, but also then how do we respond to that pandemic? And I was struck by the point early on in the Ebola crisis with some work which I was fortunate enough to be involved in on what the vaccine response should be, and should money be spent actually developing a vaccine, and was there time, and could it work? And one was the sort of the paucity of the models, but also the fact that you have to build into your model sort of the worst case scenario. I mean, you have to assume that there was going to be a transmission into Nigeria, but sort of only the most optimistic scenario would have said that there's only going to be 3 generations of spread. So you've got to produce these models whereby the asymmetry of outcome is very significant. And so I think the value here is not just, as it were, how we prepare and how we protect ourselves for these pandemics, but actually how we react to a pandemic if it comes about is a sort of side benefit of this work, which I think may or may not save enormous amounts of money.
So I very much agree with that. I was going to say in my contribution that model ambiguity is a curse of all catastrophe risk modeling, and it's as big a curse as any natural hazard when dealing with pandemics. And my discussion about epidemiological modeling on networks was by way of advocating the generation of an ensemble of alternative models, which then could be processed and then would be the basis for a meeting to be convened of experts who could then have their expert judgment elicited as to what kind of decision response might best be appropriate. In fact, in October, I should be giving a talk on expert judgment in pandemic modeling at a conference on expert judgment. And I think this is actually one area. I'm not sure if Martin would disagree with this, but I think if you just take this area about the lack of agreement amongst experts on the outcome of any particular modeling exercise, that in comparison with other areas of catastrophe risk, where in fact the resort to expert judgment in a formal elicited way is actually fairly standard now. To my knowledge, there's very limited use of formal methods of eliciting expert judgment in this domain. So in particular, what tends to happen is that country by country, you might get 1 or 2 people who would then express their own particular preferences for a model, which may not necessarily be a consensus amongst a wider group of pandemic modelers. So I'm really agreeing with you that the generation of an ensemble of models, especially for this problem of emerging pandemics, is one which I think would be very productive. And also, I should say, from the perspective of the financial markets, I think that the markets are pretty savvy now about model ambiguity, and I think the exposure of model ambiguity would, I think, be a benefit rather than a negative factor.
If you're going to respond directly, I'll let you go first. So I'm going to respond to another part of the point made in the comment, which is regarding response. And I think it also alludes to something that Martin mentioned earlier, which is, frankly, the challenges and fallibility of systems during a time of emergency, right? So you have an emergency, you're addressing a contingent fund, you've got the media, which is not going to be aligned with sort of rational risk frameworks. You have your population, which is exerting pressure. They're not necessarily going to have high levels of risk literacy. And there's going to be a whole range of possible decisions that are made which are suboptimal. Again, I think you need to layer things like triggers upon expert judgment and other traditional systems, but I do want to point out some of the benefits of having an automated trigger system, which leads to, say, the release of financing into contingency plans that lead to particular sets of outcomes. And what's nice about that is it's not subject to the sorts of political and other challenges which are naturally faced during these particular events. And frankly, they help you to have a framework by which you can naturally lubricate to sort of increase absorption capacity. So you already have mechanisms for the spending in appropriate predefined areas that are associated with particular triggers.
So, first of all, there's a comment about worst case scenarios, really. They're an essential part of modeling when you're faced with a response. There's two different types of modeling. There's the pre-epidemic, pre-pandemic, pre-emergency model, which I think in those situations you can model rather sophisticated, complicated, complex models and use them as research tools to examine a number of things. But during a pandemic or an epidemic crisis, when you're trying to decide the trigger point, it's been my experience that simple is better. For the simple reason is that you're talking to a very, very diverse audience who really don't have a lot of time to listen in depth to a lot of, here's what we know, here's what you don't. You want to keep it simple for one simple reason. You want to illustrate more than this is the estimate. You want them to understand the value of what they don't know. The data that we need, we don't have it. How important is that data in your decision making? If you want to put it another way, how thin is the ice upon which you skate? And most of the time, the ice is very thin or even non-existent. I would have to say, Nathan, I would disagree with the idea of having an automatic system. I think that's where we ran into trouble in 2009. But I think we do want to have at least a robust discussion on what the triggers might look like and how we would get to them, bearing in mind it would have to be flexible. And simple models allow that flexibility and quick reaction that you would need. So it's not quite automatic, but everybody is trained up to say, this is the kind of data we might expect, this is the kind of questions we should have, and this is the kind of models that we can expect delivering these type of data. That I would assume is automatic, and I wouldn't disagree. I just don't think we want to have this is the level, automatically do this. But certainly we should have a system in place that does help to say, do we pull the trigger or not?
Yes, just to build on what Martin has said, I completely agree that we need flexibility in our response plans to be able to handle the situation when something is not as bad as we fear it might be, or when something is worse than we think it might be. To do the trigger design and some of the work that we've done around that, we've been examining some of these factors that in simplicity, it does make it a little bit easier, and not just from the side of the responding to it, but also from a side looking at investors, something that can be calculated, something that can be replicated in, anybody could calculate it based on a given formula if that's put forward. So we've been looking at some indexes to try to use as a trigger, and some of these are really similar to what Martin's actually put forward, like a severity scoring type of system. Other methods might look at things like cases and deaths at a certain time and try to see what the potential could be in a short time period in the future. So we are looking at some of these potential triggers, and really the way to try to quantify the likelihood of achieving those, the type of modeling that we're doing on the catastrophe side, looking at many hundreds of thousands of simulations, is one way where we can try to estimate the likelihood of seeing a certain trigger point or a certain level of an outbreak. And so agreed that models are only as good as the data that feed into them, but we also have to start somewhere. We can't just wait for the data to catch up to what we need. We have to start somewhere, and then by having these systems in place, hopefully the data will then catch up to meet that level.
There was a question right back.
Thanks. My question is...
Sorry, could you introduce yourself?
Oh, yes. Yeah. My name is Tendai BT. I'm from Zimbabwe. Coming from a fragile state and listening to the colleagues over there, the modeling that you have been talking about depends on data and the quality thereof. And in a situation which exists in the majority of sub-Saharan African countries, and particularly fragile states like Sudan, Zimbabwe, Eritrea, to name a few, how do you impose a model when the data is not there, or if it's there, it's very erratic, and yet we are the region that is prone to disasters, endemics, because of our lack of infrastructure, of our lack of preparedness, of our lack of capacity. In my country, for instance, as recent as 2008, we had a cholera endemic that affected over 90,000 people. About 4,000 people died. And it happened in a very short period of time. We were not ready. The government was not ready. The international agencies were not ready. Even things that one would have thought are now more easier to predict, like droughts. We have had so many droughts, but a drought comes, thousands of people will die. So I go back to my question: how do you model in a situation where the data is basically zero, the capacity is basically zero, the institutions of execution are basically in their infancy?
Yeah, so any volunteers from the panel? Martin and then Nathan.
Okay, thank you for the question. And to make sure there's no conflict of interest, let me declare that I'm a third generation of Zimbabwean and I know exactly what you're talking about when you talk about lack of data and the difficulties of collecting reliable data. In terms of pulling the trigger and deciding where you are, you're left with only a couple of options. One is that you take data from somewhere else, it might be the US, as I said, or Australia, where they have collected data, and you're willing to, or forced to, extrapolate and say, assume the same will occur roughly in places where you haven't been able to collect data in a timely manner. To do that in any way such that the government of, say, Zimbabwe or a Sudan or a Zambia would be willing to listen, and the people who are pulling the trigger on the funds saying, yeah, okay, we believe that, let's go. You have to keep the model simple. And I have spent a career developing very simple spreadsheet-based models you put on the web. Let people download it, put in whatever numbers they like, wherever they get them from, and see the consequences. That allows the most important thing from the models, especially when you don't have much data, a discussion. So let us say you do take data from another country or even another hemisphere, and you say we're going to apply it in Southern Africa. We have really no idea how applicable and how correct that is, but we can play what if. What if the attack rate was 2/3 of what it was measured up in Europe? Would that change our opinion? Would that change our decision? If so, why? What would be? And it allows people very quickly to see what it is that would make a difference in their decision making. And if you give people those tools, in my experience, and put it right on their desks or the desks of their assistants, and there is the capacity in most countries. Spreadsheets are everywhere now. Don't know how to work it, get a 15-year-old, they'll tell you. And I've seen that happen. You can get it, but it's got to be simple and it's got to be direct, and people have got to understand what they're discussing. But you will have to take the risk, if you will, of extrapolating data from elsewhere. I don't believe there's any short answer, and it's particularly, as you know better than I do, sir, that if you say, let's go out into the field in a country in Africa and collect it, the pandemic will be over probably before you get enough data to feel certain that you've got data specific to that country. Your decision making will have to be ahead of that collecting of the data.
I'm hesitant to always be the optimist here, but
You did so well.
I do think that somebody mentioned the DRC and the Ebola in DRC. I think that that's worth mentioning, as is the just reiterating what Jordan mentioned a little bit earlier, which is the level of international investment, and whether it's elements of the GHSA, whether it's Pasteur Network or Wellcome Trust. I mean, and these things have not just been a response to Ebola. Like, for example, the Emerging Pandemic Threats Program at USAID, this is now a 7-year-old program. And these are starting to merge away from focusing on any one disease to generally focusing on epidemic threats. And so what happened in DRC, I think, is quite a useful thing to discuss, which is, and this was right in the midst of the peak of the West African outbreak, and cases emerged in a rural part of DRC, obviously a different situation. They came to a laboratory that was, this was a joint laboratory that had been supported by a number of different international organizations and the Congolese government, INRB. And what happened to the specimens was that there's a lot of Ebola expertise in DRC. Most of those individuals were actually in West Africa. So it went to a generalized lab that was set up by the Emerging Pandemic Threats Program. So it actually was not subjected to diagnostics focused on Ebola, but rather a generic diagnostic designed to identify one of a range of a variety of different diseases of potential epidemic significance, including a diversity of coronaviruses, et cetera, and that's how Ebola was sort of quickly identified. Now, that alone demonstrates that even, in a country that many people would rightfully see having a range of different challenges with regards to health development, that there is the capacity for triaging specimens, and there is really, frankly, new technology which would not just diagnose the usual suspects, but also highly diverse viruses which are present. So I think as we think forward, we should be anticipating kind of forward movement of surveillance, which I do think is inevitable. Digital disease detection, I mentioned we've ran into a colleague from Skoll in the audience. There are a range of ways of addressing this. And one point, as we think about the GHSA meetings coming up in Seoul in just a few weeks, is factoring in sort of this dynamic with financing could be important, to Martin's point. If there are representative elements of surveillance that could provide extrapolation, permitting a better understanding of what's happening in neighboring countries, and could permit sort of more rapid or appropriate flow of finances. Anyway, it's the sort of topic within the range of things that might be worth considering.
Quick follow-up question. So is there a global network of CDCs that is developing, which will have a data sharing platform, so that when you're talking about US CDC, we have somebody from China CDC here, we hear about the African CDC. So is that network developing, and is that having a data architecture that will help the modelers in the longer term or medium term?
Well, there is definitely a network, and Jordan's probably better equipped to answer this than me, but there definitely is more of a network than there was 10 years ago, and it's improving. There's better coordination, better data sharing, but data, data come from sovereign countries, and they own that, and they have the right to. and there's always an issue of what's going to happen with the data and do you agree with it. And it's not just unique between, let me also emphasize, we're not always talking about problems that are in the less developed or the countries with the least resources. Even in the US, there are states that find it difficult to go out into the community and do large-scale tests so you understand the denominator. They can tell you the number of patients perhaps in a hospital or a given hospital, but they can't necessarily have the resources to go and do large-scale investigations in the community. And during 2009, we extrapolated from 10 sentinel surveillance sites. And if a pandemic happened tomorrow here in the US, I'd be repeating the same exercise. It is difficult at any time to arrange that coordination. Again, though, let's be a little bit more optimistic. This is almost against my basic character here. Yes, it is better. There will be more data. But again, let us not kid ourselves. Just because you say there's data sharing, well, that solves the data. All the models will now be terribly accurate, and won't they be great? It'll be small amounts of data that we are sharing. This is, again, not easy. Even with these new diagnostic and rapid diagnostic tests, they are not necessarily the panacea that will solve all.
Let's go to a question that was in the back. I was saying, I don't know. Yeah, Paolo.
It was remarked in this panel and also earlier in previous sessions that as one sets triggers earlier on in the process of an outbreak, the certainty of those triggers or the level of uncertainty increases, so to speak. So if one were to assign some sort of financial cost to solving or reacting to that on the basis of that trigger, then it probably also means that there is an increased level of uncertainty if one were to respond earlier. While the figure itself might be smaller, the confidence level of that figure itself as well might be lower. So I think this is related somewhat to Martin's most recent comments. I just wanted to better understand what is currently being done to try to kind of get up the curve in terms of the reliability of triggers, and whether is the technology and the information, I guess for lack of a better description, is it open source? If we were to think of responding to a pandemic as a global good, are there pockets of information or technology out there that's actually proprietary at the moment that if were shared more openly would hopefully get us more quickly through this curve? Thank you.
So I think those are intriguing questions. I think that, again, I think that data collection systems are improving, but again, you're quite right. The earlier you want to pull the trigger, the more uncertain you are. There are more data being collected, but remember, it's through government agencies mostly. And governments, you can't expect them just to put it up on the web. They want to absorb it. They want to understand the ramifications, the planning, and the policy of that, and not be led by other people telling them what to do. If you think that's going to be anything else, I don't think that's correct. So there has to be a consensus within the government to allow the analysis of it and then put it up on the web. That putting it up on the web is always a good idea, allowing open source. But many times there are issues of, who owns the specimens, what are the legal and other consequences of those specimens, what does this data mean? They do get sorted out. But most of the decisions, important decisions, are made in the background of that data before it all becomes open source, because if you want to do it early. If you want to wait for the time that everything's carefully sorted out, put up on the web, then analyze it, and then make a decision, you'll be too late. I'm not sure there's a quick and easy answer in saying there's this idea that, you measure something and you just make it publicly available and it's all transparent. That's not how surveillance works in public health. You're dealing with public who do have the right to be anonymous, for example.
Well, thank you. Hans Trutzen from WHO. I think we're making a mistake. it's not going to be an Ebola outbreak next time. It's not going to be Spanish flu. It's not going to be HIV. What we're grappling with is the unexpected. It's the unknown. And still, we are too much building on the experiences we have with these outbreaks. And it's easy to say, what else can we do? But I'll follow up on what Martin said, and that's my own experience. When I was in Vietnam, Vietnam had tested a lot of specimens for H5N1 negative, and say to be in the public good. Then there was I won't mention which country, but it was a highly developed country, a high economy country, high income country, with well-developed laboratory, who rerun those tests and found that 250 of them were positive. I was then WHO representative in Vietnam, so I was called in on this one. Geneva, we had telephone conferences with Geneva and later on also with CDC Atlanta, and they wanted to pull the trigger. Fortunately, we did not, because we put in a mission that rerun it again, and it turned out that this was actually a false positive test was because they have used the wrong primers or not good quality primers. So when we're saying the data and when to pull the trigger, it's the reliability of that's in the bit of the unknown. And then coming to, but still I'm very much for modeling and projections, but the really problem we have, and to link it to financing, is that if you pull the trigger too early, you will very quickly lose all your credibility. We already have some experiences. I won't mention which one, but we have those experiences. And you will run out of your financial resources very quickly. And you will have the situation where people will not believe you when it's really needed there. The other option is if you pull the trigger too late. And that's what we said. When you have the exponential, you often come in too late. And Ebola was one show that, for example. So how do we get it right of pulling the trigger not too early and not too late, using modeling and projections based on previous experiences, but should be applied for not something we don't know? I think that's the key question.
So, first of all, I can't agree more with you in saying that there is a big danger in always planning on the future, relying totally on history. And you were the person with the H5 in those studies. Thank you. You saved me a lot of work. But yes, we have examples. One example in 2013 was the H7N9 cases in China. As you know, there was sustained transmission. Fortunately, it was in poultry. And there was some poultry-to-human transmission, and a few cases, but very limited, of human-to-human transmission. Did we pull the trigger? No, but what we did do was a lot of modeling where we would directly ask, what if? And the reason wasn't so much to pull the trigger, but to have a quick first assessment saying, if this were to develop, where are the gaps in our preparedness? But not necessarily go to the funding. In this case, it would have been the Congress. That's our insurance corporation. And say we need the money, but just to line this up and start the thinking. That put us ahead of the game, and the leadership at the time told us it was very useful. But we did a lot of guessing, and we emphasized it. We had no idea what the R0 would be or what the transmission. I had one of my fellows make it up. And we emphasized that, and we said keep it very simple, and that was all understood. At least I told it was. So I think, again, it's understanding that in this point of uncertainty, models aren't going to save you. They're going to help you understand how much you know, how much you don't know, but you're still going to be faced with this god-awful situation where you will be pulling the trigger or discussing pulling the trigger with a great deal of uncertainty. And you have to accept the fact that you're probably going to make a mistake many times. And so that suggests you want a contingency plan. What if you pulled it too early? What will you do? What if you waited too late? Is there a way to speed up the response? I don't think we've discussed that. That's the second generation once you've figured out some of this funding stuff, which, despite my comments, I do want to assure you, I think this is all a great idea. I just want everybody to understand the parameters that decide how much funding you should have and what it's been used for are very difficult. So if you have an understanding of how little you know, you should also build that into the planning and say, what if we get it wrong? What's our backup plan? What's plan B?
I think having any sort of detection system, you're always going to have false positives, no matter what the nature of the risk, and there's always going to be questions of data quality. I do certainly think that the nature of potential catastrophic epidemics that we face is hugely broad, and focusing on a few particular cases is a terrible idea. Having said that, I do want to go back to a comment that Aaron made in an earlier session about what I think he referred to as pre-emergency triggers. And I think that this corresponds to some of the, sounds like excellent work that WHO is doing about sort of rethinking through categories of emergency classification. But I think that the not giving ourselves the capacity to have a sort of transparent trigger-based response in a pre-emergency situation seems to take part of our arsenal away from us and not permit us to actually have the kind of impact that we could have.
So I don't want to be drawn on the definition of a Goldilocks trigger, which is exactly right. But what I would like to talk about is the need for improved surveillance in countries of Southeast Asia, like you mentioned, Vietnam. And quite apart from this whole question about pandemic financing, the big elephant in the room is providing funding for improved veterinary surveillance. So there are just so many countries around the world where the level of surveillance is extremely primitive. And one sort of bright ray of hope I'd like to leave the room with is that there are some individuals within the life insurance community in Singapore who have taken a very strong initiative to try to see ways in which they could contribute to the funding of improved veterinary surveillance in some neighbouring countries around Singapore. And I think so, this would be potentially a real game changer. I mentioned in my first panel the situation in London at the time of the Great Fire of London, when there was no fire service, but the insurance industry took it upon themselves to pay for the first fire service in Britain. And there's no reason why the life insurance industry could not make some contribution to funding so badly needed veterinary surveillance in the poorest countries. So, whereas obviously with the limited data and surveillance available in some countries, the definition of a trigger becomes extremely fraught. What one can say is that that dearth of data is an invitation for major stakeholders like the life insurance industries to stump up funding to help pay for the surveillance which everyone recognises needs to be undertaken.
Thanks. Dora?
One challenge is to be able to extract what is the essential commonalities that then also is likely to be applicable to the future. And I think one point that Nathan particularly has alluded to several times, and I think, and I belong to the medical mafia, we are overly focused on cure, and now we have great opportunities with the tools we have for HIV/AIDS and for malaria and perhaps other infectious diseases to change the mentality from case control to transmission control. And And I think that could really very much help strengthening the system in the countries to actually to be better prepared. And I tried to look at maps for malaria and maps for HIV/AIDS at the subnational level in Africa, and it has been very difficult to find out anything of any importance. And at the same time, you know, we had the article in Science by Bob Snow et al., which showed in Kenya that malaria had a spring in Kisumu on the Victoria Lake and a sink in Nairobi, and they could follow it molecularly by the parasite and by movement of people by the mobile phones. Coming back to some generic points that relevant to what Gordon is concerned about, I think there are two generic points about the outbreak in West Africa that may be worthwhile pursuing. The health system in terms of health workers, the coverage of vaccination and all that, was very hard to distinguish those three countries from anything else. But I think that there was one thing that was very clear, and that was the tremendous distrust between the health professionals and the communities. And I wonder whether that is worthwhile monitoring, because I think that is going to be a generic challenge, irrespective of what kind of outbreak and where it happens. And the other point, coming back to, I think, the director that took over CDC in 1977 was Bill Föge, and of course his surveillance containment discovery running out of smallpox vaccine in the 60s in Nigeria, where he put emphasis on following the people and their movements. And is there a case for kind of more perhaps mass data analysis available all the time in terms of movements of people, which is likely to be important wherever the outbreak comes?
Thank you for your comments. I as well agree that the population mobility and tracking populations and their movement is very important for understanding how epidemics spread. And it is something that we have been looking at in our modeling. The data that we're using include, on the grand scale, things like air travel patterns, passengers per day, but also more local movements, migration patterns, or commuting patterns within certain communities. So I agree wholeheartedly that it is very important to look at that aspect. On another point that you made about generally trying to track the distrust between health professionals and the communities, and that helping on a broad scale and applicable to different types of outbreaks or different disease classes. I agree with that as well, that anything that we can do to strengthen the systems overall, whether it be surveillance or better data or tracking human behavior metrics or population distrust, all those things are very important and need to be done. And so this is something, you know, is the funding going to come from this sort of a thing, or is it a separate stream? But I agree that this is something that is important to look into.
I think it's also important to note that the kinds of data that we're getting are changing all the time. If you look at the field of digital disease detection, if you look at the potential for phylogeography to give us indication of certain kind of transmission characteristics of particular epidemics, and frankly, while to Gordon's point, I've spent much of the last 15 years arguing for more effort for surveillance for novel epidemics, I really do believe, I mean, if you look at sort of GHSA funding, if you look at where a number of partners are, I think we're, relatively speaking, at a better position we've been in 15 years. We're going to have to start dealing more with coordination and quality of surveillance. But I think I just want to come back to one point, is if you look at the number of natural catastrophes that are subjected to epidemic risk transfer, you get things that are, of course, harder to model than epidemics, like terrorism, right? And there's a larger market for terrorism risk transfer than there is for epidemic risk transfer. The reality is, already on the books of these organizations, you're talking about a substantial amount of epidemic risk. So effectively, there already is a sort of a trade and a financial transfer that's occurring, whether implicit or explicit, of these sorts of risks, which just means that there is a baseline. It may not be a great baseline. We may have false positives that'll happen and have to redefine expectations associated with when triggers get pulled. We're going to, hopefully data quality continues to improve. We can't fully count on that, but it sort of already exists, and the notion that we wouldn't take that as an opportunity to add to the to the set of things that we have to address these potentially, and not even potentially, clearly catastrophic events. It just seems very obvious to me.
I'd like to pick up Nathan's point about political conflict and pandemic. One of my nightmares is the two coming together in a particular territory, so that the possibility for any kind of intervention would be very remote. So, for example, if one thinks of Sierra Leone, well, thank goodness the outbreak of Ebola did not take place in the 1990s when there was a civil war in Sierra Leone. And if one wants to come up with the ultimate nightmare scenario of a huge pandemic occurring during a global conflict, then one need look kind of further back than 1918, because in fact, according to kind of popular theory, the pandemic was brought to the Western Front by a cohort of 100,000 Chinese laborers who were dispatched there by the Chinese government. And so you have a direct connection there between one nightmare scenario, which is a political conflict, compounded by a pandemic. And so in terms of defining a trigger, a real fly in the ointment is a situation where there could be an outbreak of an emerging pandemic in a country which is at war or civil war or conflict, or in Syria or many of the other countries in a state of conflict. And then, well, essentially the whole kind of trigger scenario would quite likely go out the window. So I would just raise this as this particular nexus between political conflict and emerging pandemics is one which I think is a serious worry in our dangerous times.
So we'll take two last questions. We're coming close to the end of this session's time. So there's one right at the back.
Is this on? Okay. Anne-Marie Kimball from Chatham House. I have a question. When you speak about mobility, I think it's terribly important. And in the Stocking report, they were very emphatic that the trade and travel embargoes, particularly travel embargoes put in place by airlines, were counter to the IHR and should not happen. Have you all looked at evidence base for particularly, I mean, not in this epidemic, but in others, air travel? Because in SARS, when we had that super spreader event in Singapore, I mean, yes, it was in Hong Kong, it was definitely because it was a travel hub. So the countries are not working on an evidence base, but is there an evidence base counter to that WHO can use in its subsequent post-action discussions to make sure we don't see that again?
I think I'll focus more of my response on the modeling that we did about the risk of travel. We did do model both of the risk of the spread of Ebola, simple models. It's amazing actually how much information you can get out just by looking at sort of aggregate distances and population pressures and what's the risk of onward spread to a previously uninfected county or across the border. We were quite accurate on that. And on also air travel. The problem very often then becomes then that you actually need to refine your estimates, an enormous amount of data, because all you have is the average risk of becoming ill, but you don't know what is the risk of those getting on the plane. Is it the same as that in a rural village? The obvious hypothesis would be, no, it isn't. Okay, then what is it? And so again, build a simple model where you say assume homogeneous mixing, which is obviously wrong. But that represents some level of estimate, and use that, and we did. And we spent a lot of time working with leadership trying to calculate out the potential risk of a case arriving in the US. And of course, as we know, they did. Not a lot of them, but it did show the probabilities of the spread of a disease, even when you're aware of it, and even when you do things like limit air travel and the carriers stop flying, so there's limited propensity to get on the plane simply because there isn't enough seats, etc. So you do have some of that, but again, I think it was a perfect example of, yes, we can model it. Yes, you can say that there is opportunities, but getting a definitive, accurate estimate isn't part of what you're going to give. What you're going to do is illustrate the importance of understanding who gets on the plane and their risk of getting the disease versus the general risk within the population from which they come. And do we know that? How long will it take? Longer than you have to make a decision on that. Again, the simple parts of modeling and keeping the model simple to understand was the most important part in that discussion. And I think, can we have Jordan?
Yeah, we'll have the last question from Jordan. I know some others have questions. There'll be a reception right after this. I'm sure. And Jordan.
Yeah, thank you. I just wanted to make a couple of comments. I think that one of the takeaway messages is that, you know, the modeling to help as a trigger point is only as effective as the data that goes into the model. And I think that we've been talking about a number of things across the room. One comment was, are there surveillance models or a network of WHO or CDC surveillance systems? There is for sub-Saharan Africa the concept of integrated disease surveillance. It's been rolling out for a while. The problem is that the workforce that supports it and the commitment of financial resources to make sure that there are people actually out there collecting that data and that there is some level of monitoring, because the quality of data is ensured by monitoring. If there's no monitoring, there's no quality. If no one seems to care, then the people responsible for collecting the data, you know, they don't submit, and then what you get is a run out of the forms in the field, or people just making it up because their boss wants it reported, or a variety of things can happen. So I think the most important thing now from this experience is that we know that the disease started sometime in December. It's clear through the look back, you know, that it was moving around. There was no surveillance going on. There was no reporting of this. And believe me, you know, clusters of death among healthcare workers in clinics and in rural areas, that should have been a trigger. So there was no surveillance. I mean, there clearly was no surveillance. Once there was confirmation, you know, there was a response in March, kind of tailed off, but then that second wave was also undetected. And so I think by June, you know, it was clear, I mean, that there was a big epidemic happening. And I'm not sure what a trigger is, but, you know, if it's not a public health emergency of international concern, some kind of trigger should have mounted some kind of emergency response as early as late June. I mean, CDC activated its emergency response center in early July. It should have happened before August 8th. And there was enough data there to know that. And then in future testing, we know at the end of this epidemic that there are thousands and thousands of survivors. That's a good thing, but we also know that sexual transmission risk is real, and even though it's probably not a common mode of transmission, it means that we have got to continue to do testing. We have to have a lot, if we don't have lots of false positives, then we're not doing our job. We need to be out there thinking that there could be Ebola for the next 12 to 18 months, testing routinely, making sure that systems for testing and triggers for looking for Ebola are in place, or it'll come back again. Maybe not on the scale of what it just was, but on a scale that's completely unnecessary. And we also know that when we do our testing, we're going to have to test for other things too. We know that roughly a third of our Ebola positive patients also are malaria positive. So we know that there's more than just Ebola, and we're going to find other things, and we can't assume that if we find malaria, it's not Ebola. So there's so much that needs to be done, and it starts with making sure that this investment made in contact tracing teams and people going out looking for Ebola across all the prefectures, districts, and counties is not lost. There is a workforce there that knows how to do this now, and that could be the surveillance system that could come forward. The surveillance systems doesn't need to be a lofty, high-end place, building with TV screens and high-level things. It needs to be just a systematic way of doing things. And data, if it does go to an electronic platform, it's collected in a way that it can be integrated. There are ways to do that. It's not complicated. And we need to invest in that integrated disease surveillance system platform to ensure that, if we do start to see something is real and it's confirmed and it's growing, then the modeling actually that you want to predict how big of an urgent need is required is actually based on some good qualified calculation. So I sort of ranted, but there were a lot of pieces of the discussion that I just wanted to try and wrap up. So thank you for the opportunity to speak.
Any last comments, panel?
I learned never to comment after Jordan.
Thank our panel.